So next one is going to be the facial nerve. We need to know the origin and the intracranial course and the branches of facial nerve. Remember, we talked about the origin early. So the facial nerve usually comes from the facial nucleus, which is that, and the facial nucleus is in the midbrain bone medulla. So I think it will be pons. So it arises from the pons, okay? So that's the facial nucleus, arises from the pons. The cores, it comes out from there, and then a few cores, small cores inside the cranium, and then enter the internal acoustic meatus to facial canal in the petrous part of temporal bone, and comes out through the stylomastoid foramen, and then enter the substance of the parotid gland, divide into multiple branches, multiple terminal branches that we're coming to them now. So the course, CP angle, then internal acoustic meatus, facial canal, stylomastoid foramen, substance of the parotid gland, and then exit. Okay, as you see here, so this is the facial nucleus. Okay, facial nucleus, that's the facial nerve in there. So very small cores inside the cranium, and then enter the internal acoustic meatus, and then the facial canal. You have here the genicular body, and then we'll leave through the stylomastoid foramen, which will be sort of here. Okay. While it's inside the middle ear, it will give branch to the stapedius muscle. And this has significance, right? This has significance. As you can see, it's closely related to another nerve, which is called vestibulocochlear nerve. So any tumor or schwannoma in this area can lead to paralysis of both facial nerve and vestibulocochlear nerve, such as acoustic neuroma. All right? Well, so the branches at the end, when it comes out of the substance of the parotid gland, it will give temporal branch, digomatic branch, and then buccal branch, marginal mandibular branch, and cervical branch. As we said earlier, it gives branches to the stapedius muscle and the stylohyoid muscle and the posterior belly of digastric muscle as well. Well, so yeah, these are the branches. We talked about the nerve. It's coming from the nucleus, the facial nucleus, and then small course inside the brain, and then enter the facial canal. As you can see here, it gives the chorda tympani as well, and it comes out through the stylomastoid foramen, as you see there. Okay, while it's coming out, it gives a branch in here to the digastric muscle, the posterior pili, and the other muscle, which is the stylohyoid muscle as well. So you have here, this is the stylohyoid muscle, and the other muscle is the digastric muscle as well. Okay, posterior pili, and the facial nerve supplies those two muscles in there, and then we'll continue and then divides into 5 terminal branches. You have here, this is the temporal branch, this is the zygomatic branch, that's buccal branch, and then marginal mandibular branch, and finally this is the cervical branch in there. Okay, so these are the facial nerve and its course and branches as well. Okay, in the ear, muscle in the ear supplied by the facial nerve, we mentioned the stapedius is supplied by. So upper and lower motor neuron paralysis, facial nerve paralysis. So would like to say, if you have a patient face, so usually the upper, if this is the patient face, just very quickly, if that's a face, let's make it a square. The upper part, each side of the face, will have bilateral representation as upper motor neuron on both sides. Okay, so what does this mean? So usually the upper motor neuron is basically from the cerebellum or the cerebrum all the way down, so basically from the motor area all the way down to where it meets the nucleus. So this is the facial nucleus now, and then the lower motor neuron from the facial nucleus all the way down to the muscles. Okay, this is lower motor neuron. And as you see, I that's not accidental, so I drew this on one side and this is on one side. That means if this is the midline, that means there is crossing in here. However, the upper part of the face, if these muscles are upper face, the upper part of the face will have bilateral representation, like that, in the motor area. So this is, let's say, right and left. It will have bilateral representation. So what happens when you have a lower motor neuron? So it will be ipsilateral as a first instance, ipsilateral, and most importantly, upper and lower are affected. But if you have motor neuron is affected, upper motor neuron, let's say it's here. So one, it will be contralateral, and it will only be the lower part of the face because the upper part will be spared as it has bilateral representation on the motor area. Okay, so upper motor neuron, contralateral lower face, lower motor neuron is all ipsilateral face. Yeah, when you look here as well, so this is the lower motor neuron, as you see here. Okay, and when you go up to this lower motor neuron lesion, and you go up all the way up, so it doesn't have bilateral representation. It's a unilateral representation on the contralateral side, which is that color. So injury to that will lead to contralateral, or sorry, ipsilateral paralysis of the whole face. Basically, you have drooping of the mouth, loss of nasolabial fold, cannot raise the eyebrows, and so on. Okay. So the nucleus is divided into two halves, upper half to the upper half of the face, and lower half to the lower half of the face. Upper half supplied by the contralateral and ipsilateral motor cortex. So it has, like we said earlier, bilateral representation. Bilateral representation. Lower half to be supplied by the contralateral side only. Therefore, upper motor neuron lesion still get ipsilateral motor cortex. And this is the explanation why the upper motor neuron is contralateral, lower face only is affected. Type of facial nerve and acoustic neuroma, that would be lower motor neuron. Acoustic neuroma patient hear louder voice on the affected side. Remember when we said the facial nerve gives a branch to the stapedius muscle? So when this is paralyzed, the muscle will be very loose and they will have wider oscillation and heightened by the reaction of auditory ossicles, and the patient will initially hear the voice louder and later on will completely lose the hearing on this side. Okay. Quickly, great auricular nerve, we mentioned it. Remember the Frey syndrome and its relation with the auriculotemporal nerve. Root value is CTN3, and area supplied is basically the angle of the mandible and the area over the parotid gland on the outer side of the ear and the outer side of the face as well, upper half of the face as well, lower half of the face, sorry, lower half of the face, parotid gland, angle of the mandible, and ear as well. Okay.